Are you ready to advance your career in one of the most dynamic and impactful fields in healthcare? Welcome to the Cardiac Critical Care Fellowship, an entirely online program designed to fit your busy schedule, offering 3 comprehensive modules, each worth 30 credits. Learn from world-class clinicians and gain access to evidence-based content, cutting-edge research, and real-world case discussions in cardiac critical care. This program is tailored for self-driven learners who want to take control of their education and unlock their potential. Whether you're managing critically ill cardiac patients or looking to master ECMO, mechanical circulatory support, or perioperative care, this fellowship will empower you to excel. With flexible, interactive, case-based learning, you'll gain the skills needed to advance in this high-stakes field, all while earning certification to boost your career. Join us today and start your journey towards becoming a leader in cardiac critical care. Are you ready to make a difference?
Good day, everyone. Welcome to our webinar in Cardiac Critical Care Fellowship Program. This is Dr. Ashfaq speaking. First of all, I want to extend a warm welcome for moderating the session. The webinar 10 minutes with 10 minutes question at the end. Feel free to post question in the QA box. Without further delay, the mic is yours, Dr. Abdullah. And Dr. Anas, you can share your slide. Thank you.
Hello, everyone. Can everyone hear me?
Yes, we can hear.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you, Dr. Ashwaq, for inviting me and my dear colleague, Dr. Anas, to present in this webinar. And I would like to extend my thanks to all the attendees and all the organizers. It is really my distinct pleasure to introduce our speaker this night, Dr. Anas Al-Zahrani. Dr. Al-Zahrani is a highly esteemed consultant cardiology. He specialized in cardiac electrophysiology. He also had an experience in inherited arrhythmia. He served as an assistant professor of medicine and cardiology at University of Jeddah in Saudi Arabia. Dr. Al-Zahrani today will present to us a highly critical and practical topics, the art of post-operative pacing rescue. In this lecture, he will guide us through the complexity of peri-operative pacing programming, particularly focusing on how to manage a patient with cardiac device who require urgent surgery. He will cover essential device check and troubleshooting and pacing optimization, and how to handle a special situation, including device with mechanical circulating, which almost all the ICU specialized dealing with in daily practice. Please join me to welcome in Dr. Anas. Dr. Anas, the mic is yours.
Thank you, Abdullah, for the introduction, and thanks for this invitation. I'm happy to present this topic to you, and I'm hoping that my slides will be helpful and beneficial to everyone. So our objectives today is we're going to go over peri-op pacing programming. We're going to talk about troubleshooting and pacing optimization. We're going to go over a few pseudo malfunction cases or features on our pacemaker devices, and then we're going to shed the light on the devices with mechanical circulatory support, and then we'll go over a few cases that might be encountered in the ICU setting in general. So we'll start with the peri-op pacing programming. So we get a call from the nurse doctor. This patient is going for an urgent surgery tonight. What should we do with his pacemaker? Should we fix anything? Should we program it? And should we call anyone to help with this? So first of all, whenever we have a patient who's going for a surgery who has a device, any device, ICD pacemaker or a CRT device, first of all, we have to check the device type and the device brand. What was the indication for the implantation? When and where was the device implanted? What was the pacing mode? And how's the battery doing? And then we have to check basically if there was any recent interrogation or when was the last interrogation done, if there were any issues with those interrogation sessions, how was the battery doing, was there any specific recommendations at the time of the interrogation, and then we have to would say risk stratify, but maybe check the surgery itself. Is there any risk of electromagnetic interference on, and if possible, what type of cautery, and what is the site of the procedure? So, because typically procedures with or are procedures or surgeries that are done using cautery below the umbilicus have smaller risk of interference compared to above the umbilicus level. And then our initial assessment of the device itself has to go over current rhythm, what was the pacing percentage, was there any atrial or ventricular events, and how's the battery life, and if there are any observations or alerts that we need to take care of before the surgery. Then we typically do the general pacing tests, or we test the general pacing parameters, including R and P waves, sensing the pacing thresholds, impedances, and for ICDs, we check the therapy zones. We should review the events if there were any events that haven't been seen during the last interrogation or in the meantime, and whether whether there were therapies delivered and whether they're appropriate or not based on the EGMs if present on the device. So if we take an example here, so we have a 65 years old gentleman who's 2 days post anterior MI. He's got a proximal LAD, PCI, and stenting. He also have a dual ICD that was implanted 3 years ago for paroxysmal heart block with a low ejection fraction. So patient now is having acute left leg pain in the ICU, and this is concerning for ischemia, and we're going vascular surgery. So what should do with the device? So first of all, we checked what was the device. So we know the indication. It was implanted 3 years ago. It's on the left side. It's a dual device, so ICD-TR with two active leads. And then the last time it was checked about a year ago, the ventricular pacing percentage was less than 1%. The patient's not pacing dependent. There's no arrhythmia, no shocks. And we know that this patient is going for a vascular surgery, probably actually below the umbilicus, so it's low risk for cautery. So this is the interface of Medtronic devices. What we typically check first, the presenting rhythm on the top here. So patient's sinus rhythm is not paced. The battery got about 9 years of life, is paced 0.2%, so less than 1%. And there was no treated events. There was no monitored events and no observations at the bottom here. And then we move to the tests, including sensing, thresholds, impedances, and all this. This is the interface of Abbott devices, where basically it shows the same. So there were 8 alerts. The battery here about 6 to 7 years. These are impedances, seem stable, sensing, and the capture on the other side here. And then we go over the tests on the right side of the screen, and then we go over sensing, pacing, thresholds, and impedances testing. On a Boston Scientific device, basically the same. So the summary will typically give you a hint or a clue about the general function of the device. However, you still have to go over the tests to check the general pacing parameters and to see if there are any issues with the device function before the surgery. So we sense this, we check this patient's pace ICD, the sensing was appropriate. The P wave was around 2, the R wave was about 20. The atrial and ventricular leads thresholds were stable and comparable to the baseline. The impedances were stable as well compared to the baseline, so we turned the device therapies off. In patients who are, let's say, pacing dependent, then we check, let's say the patient's heart rate is paced at 50, we can put the pacing or change the pacing mode to, let's say, VOO or DOO, 70 or 80 beats per minute or 60 beats per minute. And then that way we make sure the device doesn't sense or get interfered with by by any electromagnetic interference. And then we turn the therapies off. So these three pictures, basically, the bottom one is from a Medtronic device. So we have to go over we have to go over simply over each therapy zone and turn it off. On the top left one, this is from Abbott. So again, we go over tachytherapy is enabled and we click, and then that way it's disabled here. And then on Boston Scientific devices, we go to the tachy mode, and then we click on it here, and then we can turn this to either off or monitor only, and then we can also enable the electric cautery protection. So that way, patient is pretty much ready for the surgery device-wise, and then we can call anesthesia and call the team to take him to the procedure. So patient had a procedure done, or any patient who had a procedure done, what are the things that we should watch for post-operatively? So first of all, we have to check for any new bradycardia or pacing failure. If there were any frequent PVCs or sustained VT or VF, which can typically happen mostly during cardiac surgeries and with bypasses or valves, or due to tissue manipulation, and sometimes due to reperfusion as well. We also have to check if there were any any ICD shocks or any therapies in general, and whether those were appropriate or inappropriate. Although we turn the device therapies off, but sometimes things can go very fast and we don't check the devices. But so that's just what we have to watch for after the surgery. And then in those surgeries where the patient gets heavy anticoagulation or high doses, we need to make sure that the pocket where the device is implanted is not swollen, there's no hematoma or bleeding. Typically, this is less common in devices that were implanted a long time ago, but in general, in recent implanted or swelling and hematoma could happen too. And then we check if we need to interrogate the device early, if there was any change in the rhythm based on cardiac monitors or ECG, or if there were any change in hemodynamics, especially in CRT patients and sometimes in pacemaker patients, or if there were any device therapies that are seen on cardiac monitors. So to put it in a way that's easy to remember, we could say lead, threshold, sensing, shock therapy, and then eventually bleeding and infection. So we get to test the first parameter, which is the sensing of the pacemaker or an ICD. So it's very essential to assess this sensing function because it helps with pacing and as a general parameter of lead integrity. And then we compare those levels to the pre-op level or the baseline levels and make sure these levels are acceptable. Low atrial or ventricular values could lead to over sensing if the device is adjusted at low sensitivity levels, or under sensing if they were programmed at high levels than sensed waves, and this increases the risks of complications as well. So you could see here on a Medtronic device, it sensed the P wave at 1.4 and the R wave about 20 or more than 20. And then based on the numbers that we see, we basically adjust the sensitivity level here. 5.6 a bit high, but then it depends. This is the main thing is that especially in ICD devices, if the R wave, let's say, is about 6, we have two things to keep in mind. Number one is that the device does not sense the P wave as an R wave. And on the other hand, we want to make sure that whenever those patients are going through a VF or VT, that the device sense those. So we don't want to make the patient's ICD less sensitive by increasing the sensitivity, and at the same time, we don't want it to be very sensitive with low sensitivity to oversense the P waves or other signals on the leads. The second function that we have to test is the pacing threshold. So the pacing threshold typically is a check for lead capture and integrity, and we have to check each lead separately. So in a CRT device, I've checked LV lead, RV lead, and A lead. In a dual device, we check the A and V separately. The numbers are typically higher immediately after implants, and sometimes, and they get much better 3 to 6 months after the implant once the tissue contact or the tip tissue contact is complete. We always have, as I mentioned, to compare the new levels or the levels we find to the baseline levels, because if the patient has high threshold to start with before the surgery, high thresholds after the surgery within the same range is not a big issue. It does tell that maybe the lead is getting older. There's some chronic issues with the lead rather than a new issue or an acute issue that happened during the surgery or before or after the surgery. And high thresholds could be a sign of either lead dislodgement in general, especially after procedures or surgeries. Chronic chronic high pacing thresholds levels could be due to lead mineralization or dysfunction. And the problem and the main concern is that this might depletes the battery sooner than later, meaning that the patient will require more pulse generating or pulse generators change. If the lead is dislodged, then it has to be repositioned. If the patient is requiring higher, typically we give it a double safety margin. So if the pacing thresholds at, let's say at 3, we make it 6 or even up to 8. The point is we ensure if there is any problem with thresholds that the patient's getting paced, and especially in those patients who are pacing dependent. And then we can test the impedance of the device. The impedance basically is a measure of the resistance that the electrical current faces during its flow between the device and the tissue. So high levels or high impedances are generally seen in lead fracture, or it can be a result of loose set screw or loose connection with the set screw. Now, this happens typically right after the implant, but if there's a lot of time between the implant and then the patient has high impedances, they'll be more concerned about lead fracture than loose set screw. On the other hand, low levels are concerning for lead insulation break, and both ways or both problems would affect the device ability to sense or pace appropriately, and this can be an urgent need to reposition or replace the lead, especially in patients who are pacing dependent. And it might might require a temporary pacing insertion or applying transcutaneous pads if the procedure can be done safely and soon enough to save the patient, putting another line or a line in in the heart. Now, there are other things that we need to watch for other than the device itself or leads themselves. We can, especially in the ICU settings, there are some medications or in general cardiac medications that might be affecting the pacing threshold or the defibrillation threshold, and that we have to watch for. And also things that, or medications, as we know, that might improve the patient's pacing threshold, including isoprel or dobutamine or norepinephrine. But looking at the antiarrhythmic medications, if we look at flecainide here, it looks like it increases the defibrillation threshold and pacing threshold. Oral amiodarone, especially with high doses or high accumulative dose, can increase the defibrillation threshold as well. And there are other medications that we could see that might have neutral versus a negative effect on the pacing thresholds. What else to watch for other than the device medications? Actually, electrolyte disturbances or disturbances in the pH of the blood, either acidosis or alkalosis that might affect. So here, the hyperkalemia have actually variable effects on the pacing thresholds. A mild hyperkalemia increases the excitability and makes the membrane more sensitive. That helps with the pacing thresholds. But actually, on the other hand, significant hyperkalemia makes the resting membrane potential less negative and partially inactivates the fast sodium channels. So that way it reduces the upstroke velocity and excitability of the working myocardium. And we're talking here about significantly high levels that will probably act on anyway, like anything above 6.5 or 7. On the other hand, significant hypokalemia can also increase the pacing thresholds as well. Systemic acidosis does significantly increase the ventricular stimulation thresholds at all pulse widths, as seen in animal studies where it was shown that acidosis does significantly slow AV nodal conduction and prolongs as well the Winke-Back cycle. Now, alkalosis as well, often when combined with hypokalemia, increase the pacing thresholds as it change the ionized calcium and sodium balance and affect the sodium channel availability and excitability, especially if combined with a class 1 antiarrhythmic medications. Other than this, hypoxia, myocardial ischemia could also alter or raise the pacing threshold. So these are the things that we need to watch for if there were any issues with the pacing threshold. So we start with the device function and we check the parameters and test them, and then medications and if there were any electrolyte disturbance. And I assume we're in any ICU or any medical setting, we'll probably deal with those issues anyway, even without effects on the device function. And then after that, we basically check for observation. So it's very important to check if there were any atrial events or ventricular events, or if there were any therapies delivered, and we have to review the EGMs to make sure these therapies were appropriate and whether they were successful or not. And this is basically a patient that I've seen during my training where he went for a TURP case. He was about 78 years old, and after the procedure, the anesthesia team referred him to us to check because during this on the cardiac monitors, they could see that the patient was having multiple events of rapid ventricular pacing, so they weren't sure what was happening. And then when we interrogated the device, it appeared that the device was the cautery actually affected the device function, and it did show some noise. That noise did trigger the device or the VF mode, and then the device recognized this as a VF and then started with a ventricular pacing therapy until it was charging to deliver the shock, but eventually it was diverted as the cautery stopped. So then moving to the sorry, go to the next slide in here. So what measures can we use to help our understanding of what's happening with the device? We typically start with an ECG to check and see if there are any issues. We interrogate the device, and then a chest X-ray is always helpful to check for any dislodgement, displacements, or perforation or micro dislodgement of the device, and to see if there were any issues. Also helpful to see, especially in some cardiac surgeries where the patient might get pneumothorax, which can sometimes affect the pacing function, either mechanically, actually more mechanically on either the device side or the leads insertion into the veins. And then in occasional cases where there's a high suspicion of lead perforation, CT chest can help as well. And the cardiac electrophysiology consultation or the device's team involvement is always helpful, as indicated, to assist with device programming or to troubleshoot things if complicated. So here are some of the common scenarios that we see after surgeries. Some of these cases are cases that I've seen myself, and some are just collected from other resources. So here we have a 72 years old male who's post a triple bypass surgery with a heart rate of 28 in the cardiac surgery ICU, although the patient is having a functional pacemaker. So we could see from the ECG that there are pacing spikes, but there's no capture. So this can be a sign of either lead fracture or dislodgement. So chest X-ray was done, and it did show, as we could see on the bottom left of the slide, that the lead was retracted, and it was paced probably the ECG from where it was going back slowly back, and then it was retracted completely, where it lost all the capture. So in this case, the patient is pacing dependent, as we could see here, then an urgent transcutaneous pacing, putting an isopril infusion until we prepare for an urgent temporary pacemaker insertion. And if the lead was still in the ventricle, we can put the thresholds to the max, or the output to the maximum values, if that helps, if possible, just to buy some time. And then this lead has to be repositioned or replaced later on. Another case here is that this is a 48 years old woman with an old ICD who was urged to an aortic valve surgery because she was clinically deteriorating in the setting of severe aortic insufficiency. And due to the urgency of the case, there's no time to interrogate the device. So the anesthesia team could only apply magnet to it. And then post him in the ICU. The patient had several episodes of polymorphic VT, and the ICD unfortunately did not act on these events. When the device was interrogated, it did show that the therapies were off, although the magnet typically does not permanently disable the device therapies. However, in some certain old guided Boston Scientific ICDs, it does this until it's reactivated through programming. So something to keep in mind. We don't see this every day or most of the time, but just to keep in mind to check this. Here's another case of a 69 years old gentleman with a dual pacemaker who was admitted to CCU post valve surgery, and then the nurse called you to let you know that the patient on the cardiac monitor has few pauses and the device did not pace these pauses, or it has to be paced anyway. So we could see that on this here that the patient or the device was pacing appropriately, and then apparently what it seems to happen is or happened is that the device could oversensed could oversense the P wave here. It's a bit larger than the other P waves and might have thought, well, maybe this is an R wave, I won't pace here. And then in this case, we'll probably have to recheck the device sensing, especially the ventricular sensing, to adjust this accordingly and according to the R wave. So if the R wave is good and high, then we can increase the sensitivity, so we make the device less sensitive to those small waves. Another scenario here is an 86 years old male in CCU for low cardiac output status going into a cardiac shock. He's known to have cardiac amyloidosis. So you're speaking to the family at the bedside, and you notice that the pacemaker is at times pacing despite having the patient own rhythm, and then at other times not pacing at all. So apparently the device here is under sensing and inappropriately pacing, which might put this patient at risk of RNT and subsequently VF. So the device interrogation showed that this sensing was inappropriate, and then the chest X-ray showed that was lead dislodgement. So the lead will need to be repositioned. There are multiple causes of undersensing other than lead dysfunction, either insulation defect or fracture or dislodgement. Metabolic causes like hyperkalemia or acidosis, class 1C antiarrhythmic drugs, myocardial ischemia or MI, and pulse generator failure, and other things like a change in the intrinsic signal, including a bundle branch block or VT or VF, or if there is any AFib, and sometimes the AFib or could be oversensed as R waves, and then or A waves in P waves in atrial-paced patients. Another scenario here is I have a 43 years old male patient with bicuspid aortic valve. He's known to have also hypertrophic cardiomyopathy and had an ICD for primary prevention here after the valve surgery with multiple failed pacing therapies for ventricular tachycardia events and requiring eventually a shock, which is typically very unpleasant to patients. What we can do in those cases is that we can check the device anti-therapy pacing or ATP settings, and then we can adjust those or give it at least a trial to see if we make them more aggressive by increasing the number of bursts and pulses or sequences, or the coupling interval, make them less. So moving from 81 to 78 or 74, especially if the patient's connected to cardiac monitors and watched. Sometimes these aggressive ATPs are more successful in delivering the therapies and interfering or terminating the ventricular events. However, we have to keep in mind that we have a backup way of treating ventricular events if these don't help with the ventricular therapy termination. In few cases, adjusting or programming the devices to have ramps or with very short coupling intervals, we could see that some of those patients, although very rare, but ended up having VF for worsening their ventricular tachycardia into ventricular flutter. And as I mentioned earlier, always consult a heart rhythm specialist or the device team to assist with programming or to adjust or change or optimize any programming issues if there were any issues. Another patient here is a 79 years old male with intractable rapid AFib post-surgery, and he's in the cardiac surgery ICU, having multiple attempts of cardioversion, now requiring higher and higher doses of amiodarone. He's got a dual pacemaker implanted for symptomatic bradycardia in 2015. And we checked the device, and the device is showing rising pacing thresholds. other than this, the device was sensing very well and the impedances were fine. The X-ray showed intact leads and the VPG was done. It shows very low or significantly low potassium levels. So always keep in mind, check and correct electrolyte disturbances, and then in the meantime, you can program the device output to the maximum until the problem is solved or fixed. Now, this is a stepwise approach or a general scheme to help with pacemakers in general if there were any issues. So, starting if there was no output and the patient is not hemodynamically stable, we have to reprogram to the maximum output in asynchronous pacing mode and immediately consult the cardiac rhythm specialist. And then in the meantime, we could try temporary pacing either transcutaneously or intravascularly, or we can put a patient on epinephrine isoprel infusion to help. If the patient is hemodynamically stable, then applying a magnet can differentiate some of the stuff. So if the pacing comes back with applying magnet, then there was maybe an oversensing issue. So first of all, we have to check if there was any nearby electrical devices that might have an electromagnetic field and could have interfered with the device function, or if the sensing is programmed as unipolar, especially in some of the old leads or in some of the leads, we have to assess for maybe potential interference with the chest wall movements, or if there was any AV crosstalk. Now, if the pacing does not resume with applying magnet, then we should connect the device to the programmer and see if that device does not connect to the programmer, maybe the battery has ended and there's a pulse generator defect. If the device connected with the programmer, then we check the impedance and other tests as well. And if the impedance is low, could be insulation break. If it's high, maybe a lead fracture. And at the same time, we should call for an urgent chest X-ray and check closely if there's any lead dislocation or lead fracture. Now, sometimes what can happen is there might be a micro dislodgement, but doesn't typically end up with no output. Maybe it requires higher threshold, but typically no output could possibly is typically a sign of significant dislocation or dislodgement of the lead. Now, if this happened, then the lead has to be either repositioned or if it's fractured, then it has to be replaced. In either cases, if high impedance or low impedance is where we are concerned about lead fracture or insulation defect, then the lead has to be replaced. And if those are normal, then it might be an issue with the pulse generator itself, and then changing or implanting a new generator might be the answer to all of this. So we've gone over a few or the basic pacing issues. Now, I'm going to talk about a couple of things that might look like the device is malfunctional, but it's basically related to the programming features. First of all, we're going to cover the pacemaker-mediated tachycardia. So this typically happen in an atrial tracking mode where like a PVC or a ventricular beat is retrogradely conducted, and this triggered on the A and leads to a fixed ventricular pacing at the upper tracking rate. Typically, either an atrial non-capture or a PVC would trigger this, and in general, applying a magnet will terminate the pacemaker-mediated tachycardia, which typically switches the DDD to a non-sensing DOO mode, and that way it will terminate. Now, most of the devices have the PMT algorithm or detection algorithm, where it does basically once it once it recognizes this issue, it increases the PVARB, or the post-ventricular atrial refractory period, to 330 in Abbott, 400 in Medtronic, and 500 in Boston, 500 millisecond in Boston, depending on the, as I mentioned, on the device brand. And this could also help. But again, we've seen PMTs in those patients with these devices and those algorithms activated. So always to keep in, it's always something to keep in mind. Another issue is that we sometimes can see that the device is missing one or two, or maybe not acting properly just from the appearance of the device. So sorry, there's something we call upper rate behavior. So in DDD pacemakers, and especially in ventricular pace dependent patients, the upper tracking rate is how fast the device will track the atrial rate. So once the atrial rate exceeds this upper rate, the device will go to what we call the device pseudo-wink-back behavior, as we see in this image on the top, where we see 1, 2, 3, 4A, and then 3 ventricular paced beats, so 4 to 3, or sometimes 3 to 2 wink-back cycle. But if the atrial rate goes beyond this, then this will lead to every other atrial beat falling in the PVARB, and this is revealed, as we see here, the atrial refractory beat, and then in that way, it looks like maybe the device is going into 2-to-1 block. So this might look like maybe the device is not functioning well, but it's actually one of the features, or the programming features, that the device does to minimize pacing of the ventricle. Now, talking about cardiac devices with mechanical circulatory supports. So there are different multiple things that might interfere with the device function in patients who underwent LVAD or RVAD or other mechanical circulatory support device or system. So something like, we give those patients higher doses of heparin and anticoagulation, and we have then to watch for a pocket hematoma or infection. Also, because of the altered ventricular geometry and the mechanical interaction during the surgery, and also the frequent arrhythmias or ventricular arrhythmias, this can lead to lead dysfunction or dislodgement, could change the pacing thresholds, or could inappropriately sense or detect arrhythmias, or even deliver therapies inappropriately to atrial tachycardia, or maybe delivering therapies in a patient who does not need therapy, or even if the therapies are or could fail to stop the tachycardia. So what we typically do in LVAD patients, we turn the therapies off of the ICD, as and the LVAD will provide this hemodynamic support that the patient loses with significant arrhythmia if needed, or sometimes we keep only pacing therapies, trying to save the patient the unpleasant feeling of the shock. With RVAD patients, there are more concerns during installation of sensing or pacing problems due to the involvement of the right ventricle. Theoretically, however, the data for the RVAD is not as robust as the LVAD ones, but we can extract few data from, or conclusions from these data. Here's a 59 years old gentleman with a CRT device, and now his post right-sided Impella device. The pacing thresholds, or actually the LV pacing thresholds, were rising, and this could possibly be related to dislodgement or even micro dislodgement of the LV lead during the installation. So always have to compare the baseline image and also compare the baseline thresholds or pacing thresholds to the current or the new ones. Now we're going to go over special cases that might be seen or encountered during the ICU stay or in any critical care setting, and whether the device helps with those situations or cases. So starting with patients with long QT. So in patients with long QT, either acquired or congenital, especially if they have, or if they've had or pause dependent torsades, they could benefit from higher pacing rate, and typically and preferably atrial pacing with prolonged AV delay if the AV conduction is intact. And the studies have shown that this typically shortens the action potential, shorten the QT, and prevent these short, long, or long, short sequences that could trigger the torsades events. And some of the studies have shown that just increasing the atrial pacing rate or the ventricular pacing rate from 50 to 60 beats per minute reduces the risk of these events from 30 to about 3% within few days, which might be explained by maybe a change in or remodeling of the ventricle or in the geometry. So those patients benefit from higher pacing rates, especially we typically put them around 80, but 80 to 110 or 100 is acceptable. In patients with multiple ectopies, ventricular ectopies specifically, increasing the lower pacing rate could help and suppress these ectopies. And if it's happening very often, or if they're symptomatic and or hemodynamically significant, along with electrolyte disturbances and antiarrhythmic medications, and maybe minimizing the sympathetic activity, the pacing rate, if it goes higher, again, atrial pacing preferably, just to keep the synchrony of the atrial ventricle going, might help. In patients with recurrent therapies or electrical storm, other than increasing the lower pacing rate, they could benefit from prolonging the detection time to allow for a spontaneous resolution of the arrhythmia if possible. So the other way also, we can turn off the shocks and leave the ATPs and keep the external therapies in use if there were concerns or there was a need to preserve the battery and the lead integrity. In slower VT or incessant VT with slow rate that are typically difficult to deal with shocks or with antiarrhythmic medications, we can try the ventricular NIPS using the device programmer. So we try to do what we do during the EP studies with the programmer at the bedside and the patient connected to monitors and a backup protection system or defib pads to internally terminate the arrhythmia, which can be successful in many cases alongside other measures. And again, if it's complicated, always consult an EP team or heart rhythm or devices team to assist with this. Now, in patients with frequent atrial ectopies or intermittent AFib, higher atrial pacing haven't shown any benefit or significant benefit in terms of reduce that being do the same with the atrial NIPS and try to interfere with the atrial arrhythmia internally through the device with pacing faster than the arrhythmia rate. However, we preserve this to the presence to the heart rhythm specialist and to make sure it's done in a safe way. In patients with cardiogenic shock or shock in general, the increasing the pacing rate, peripherally atrial with the long AV delays, if the AV conduction is intact, might help in those patients with chronotropic incompetence. Other than this, doesn't typically happen, doesn't typically help. But every case is different and decision should be tailored to each case. Electrical cardioversion is safe with in patients with cardiac device pacemakers or ICDs, but it's recommended to use the anteroposterior position of the paddles or patches to avoid the current shunting of the leads, and also ensure the pass at least 4 to 5 centimeters away from the implanted device. CPR is safe in patients with pacemakers or ICDs. Now, in some cases, internal shocks might happen during the CPR if the device is activated, and this could possibly be associated with uncomfortable tingling sensation to the resuscitator and can be avoided by wearing gloves and avoiding contact with the bed. In terms of central lines insertion, we typically recommend that it's done on the other side of the device. Either way, a chest X-ray is important to check that the insertion has not affected the lead's position or has not dislodged the leads or caused lead injury. In terms or regarding MRIs, as we know, most of the devices these days are MRI conditional or safe. But at the same time, we have to check and make sure the leads are safe as well, and they're MRI conditional, because having an MRI conditional generator or pulse generator with leads that are not conditional will make the devices MRI unconditional. Before the MRI, we turn the therapies off and we switch the pacing to the asynchronous mode in pacing-dependent patients. In patients with abandoned lead, fractured leads, or epicardial leads from the MRI is prohibited. And we also don't, or we delay MRIs at least 6 weeks post-implant. Lastly, in cases of at the end of life, or if the patient in a patient with a device, we can turn the therapies off, but we can keep the pacing function going, as it doesn't typically prevent death, and however, actually it helps ease the symptoms associated with bradycardia. So thanks everyone for your attention and for listening to this, and happy to take any questions. I'll give the microphone back to Abdullah.
Thank you so much, Anas, for the outstanding and highly practical presentation. You really have given fantastic overview in this lecture. I know the insights you shared on managing metabolic shift troubleshooting and all others topics you mentioned will help the critical care practitioners to deal with their patient in daily practice. However, we still have now some times reserved for discussion, and I would like to ask the audience to share their questions in the Q&A. You will find it down in the screen of the Zoom. Before we start taking question, let me lead or give you some few question that we can share the discussion about. So I would start to asking you what are the common pacing problem after surgery, and how can you solve them that you're seeing in your clinical practice? You hear me, Anas?
Yes. Yeah. So as I mentioned, the common the common problems, as you mentioned, in either rising pacing thresholds, and that typically or mostly post-surgery is related to lead dislodgement. And as I mentioned, we have an approach to this Other things we see basically is that sometimes the surgery or the cautery during the surgery causes some noise on the leads once checked, and then that basically will either trigger ventricular therapy, or if the therapies are off, might be concerning to people who check the device. But um, we have approach to this as well. So mostly, during the surgery or post-surgery, the main concern is the lead dislodgement, which can affect, or lead fracture actually too, which can affect the device ability to sense or pace or to function properly.
Okay, nice. So, what else other than the device? Like, is there anything you should watch or fix for the surgery? And what about the devices for mechanical circulating support?
So for devices with mechanical support, there's a couple of things. Number one is before the patient goes to the procedure, the device has to be tested just to have a baseline, and including testing thresholds and sensing and impedances to have a baseline before going through the surgery. And then we also should deactivate the therapies. Once the surgery is done and the patient is back to the unit, a chest X-ray is helpful to make sure that the leads are not dislodged, and at the same time, the device function or the device is interrogated again to make sure the leads are fine. Now, in some cases, we deactivate the device therapies after the LVAD insertion. In some cases, we don't, based on and based on sometimes the patient's preference and the history of recurrence arrhythmias, and if the patient has ever had any shocks. Um, Other devices like Impella, basically watching during the procedure, right after the procedure, getting an X-ray just to make sure, especially for the right-sided one, that the leads are in place and there were no issues with the device function, especially if the patient needs pacing or pacing dependent.
Nice. Um, Another question came to my mind, and we receive this consultation a lot in EP field, usually from surgeon, anesthesia, or ICU, about when to check the programmer before a procedure, or do you usually ask for every patient having device, regardless, like pacemakers, ICDs, or CIT, all of them should be checked pre and post? What is your recommendation in this concept?
Yeah, it's a good question. I typically recommend checking every device. Now, the importance is much higher in those who are pacing dependent, just because any problem with pacing thresholds or sensing can affect the patient directly, and it might, the time is tight and short, and if anything happens to the device, so that's why I typically recommend every device to be tested before and after the surgery. However, the importance is higher in pacing dependent patients. Um, After the surgery, I recommend chest X-rays if there were any issues with the device function, or if um, there are concerns as well, or if the procedure itself involves a possible manipulation of the leads or the cardiac tissue. Um, or it involves, let's say, right ventricular valves, or right-sided valves in patient with leads, or in patient with RV lead or LV leads as well, or like a coronary sinus leads. Um, and if the patient had his ICD therapies off, then we need typically to interrogate the device back after the surgery and reactivate those therapies if needed.
Nice. Now, there is not all hospitals having EP services, and some of them they had to run procedures with patient having devices. defibrillators or pacemakers, and they usually have the magnet. And there is always a question: what is the magnet can do for these devices? Like, what is its effect on pacemaker? What is its effect on defibrillators devices?
Yeah, so applying a magnet would typically deactivate the ICD therapies, and then pacemakers will switch the pacing to the asynchronous pacing mode in general.
Nice. And now, since we are presenting in the environment of ICU and we are surrounded with ICU's clinical practitioners, you highlighted how metabolic changes and electrolyte imbalance, such as hyperkalemia or systemic acidosis, can significantly alter the pacing threshold post-operative. So, and we usually have running like a busy ICU setting where these shift and changes can happen rapidly. So, what is your recommendation, protocols, or your clinical daily practice for frequency of the device interrogation to stay ahead of potential pacing failure?
Yeah, that's a very good question. You know, I don't have a specific protocol or recommendation, but I would recommend probably in patients with devices to have, especially those pacing dependent patients, just to check their their electrolytes and by simply getting a VBG after the surgery, or as triggered by the clinical case in general, or by clinical indication to check those after the surgery. Just or sometimes, if there were any pacing threshold issue or any pacing issues or concerns, I think it might be ideal to get the chest X-ray, ECG, check VBG, just to make sure, especially in those high risk patients where they need, let's say, someone with significant AKI or someone who's on other medications that can affect the potassium or other electrolytes levels as well. I think the importance gets higher in those high risk patients.
Great. Another question came to my mind before I move on to the audience questions. Now, you mentioned on those patients who coming with ventricular therapy or electrical storm, they having a lot of shocks for VTs or VFib, especially those post surgery and or those who came through ER and admitted and get intubated. You mentioned the strategy of turning off the shock therapies while leaving the ATPs and external therapy active to preserve battery and lead integrity. So, could you elaborate more on this specific scenarios and give us like a hint for what is ATPs mainly doing?
Yeah, that's a good question too. In some cases where patients are having frequent arrhythmias or ventricular arrhythmias, especially if those are more symptomatic but less hemodynamically significant. Maybe trying the anti-tachycardia pacing, where we pace the heart at a higher rate than the tachycardia itself, so we can get through or into the circuit and break it, the circuit of the ventricular tachycardia. And mentioning, that if we, in cases that we need to, if the battery life is a concern, or the lead integrity is a concern, sometimes allowing some or giving some time to the arrhythmia might allow the arrhythmia to spontaneously terminate, and also save the patient this unpleasant sensation of the shock. Now, this is all different, and the answer to this is very different if the patient is going through, or if the patient is getting hemodynamically significant ventricular arrhythmias and sedated, then awake, then we'll probably either sedate the patient and allow for external cardioversions in the ICU settings, or if the patient, sorry, this patient, this is if the patient is sedated, but if the patient is awake and it's hemodynamically significant, I think maybe keeping the ICD therapy shock or the shocks basically on um, would help if they're significant, if they're hemodynamically significant. I just don't want to confuse the audience and myself, but if we think that the arrhythmia is mostly symptomatic, less hemodynamically significant, then maybe giving a bigger chance to the anti-tachycardia pacing to try to stop the arrhythmia might be helpful for the patient and the device, and it saves him the feeling the shocks and the trauma that is associated with the shock. But that case is different if the patient is if the patient is hemodynamically unstable. I'd probably recommend keeping the therapies on.
Okay. A question from one of the audience: is it safe to off the pacemaker in a dependent patient?
Well, if the patient is pacing dependent, now the question comes to checking the dependency. So let's say we look at the cardiac monitor and we see that the patient is getting paced all the time. When sometimes we interrogate the devices and check, sometimes if you lower the pacing rate, let's say from 60 to 50, you'll see that the patient has his own intrinsic rhythm at 50 or 45, and maybe lowering the pacing rate lower than his intrinsic rhythm might be helpful. But if the patient is fully dependent on pacing, by lowering the pacing rate to like 30 or 35 beats per minute, I wouldn't recommend turning these pacemakers off for sure.
Great. I see Dr. Ashwag Mahtali raising her hand. You have the mic, Dr. Ashwag, if you have a
Thank
question.
thank you, Dr. Abdullah. Thank you, Dr. Anas, for your lecture. Basically, in our ICU, our patient going for a major valve change, and sometimes they develop heart block. So my question is, some of the patient will come back with temporary maker, and for those patient, they will come with high threshold, and also the sensitivity will be done by the anesthesia. And our fellow or the resident overnight, they should like adjust the setting for this spacing. Can you elaborate on this and how they should do it? Because like some as the question already answered and raised, there is some resident, they may even try to turn off the pacing by turn it off and start from the beginning. And if the patient dependent, we have a cases that arrested, and then when they turn it on, it's needed time until the charging and until the pacing delivered. So this is my first question. The second question is, some of the patient, we have the pacemaker, the temporary pacemaker, but at what time we will say this patient, he should go for the permanent pacemaker, or okay, it's already like 48 hours, we need an electrophysiology expert to decide about the permanent pacemaker. Thank you.
Yeah, thanks, Dr. Schwack, for your questions. They were great questions, great practical questions. And correct me if I'm wrong. So the first case is a patient with, or the first question is a patient with a pacemaker who goes to a valve surgery, comes back with a temporary pacer as well.
So
And then,
all our patient is going without any pacing. So they have their own rhythm, but however, post-surgery, they will develop the problem. So this is the majority of the cases that we deal with, is
Yeah.
patient who will go without need with their own rhythm, However, when they come back, either at offing the pump, they need the pacing due to the heart block, or maybe after a while, when they came to the ICU, they suddenly develop heart block, and we use the transcutaneous and eventually going for transvenous. And even some patient, like with the time, they will need the permanent pacemaker.
Yeah, so yeah, thanks. I get it right now. So what I recommend typically, because those post-operative periods, especially after valve surgeries, especially after, aortic valve surgery, even tricuspid mitral valve surgeries, what I and those patients, in most of the cases, they come back with temporary pacers. What I typically recommend that you or the team keeps the pacing at very low rate, just in case if anything happens that the patient has a backup pacing rate. I recommend against turning those temporary pacemakers off. As they're there, their backup. They're not going to do anything if the patient is having his own intrinsic rhythm. And in cases of complications, which sometimes can see, and I'm pretty sure Dr. Abdullah Shahri has seen this as well, and we've seen this a lot. Sometimes the patient comes after their surgery with his own intrinsic rhythm, and few days later he develops complete heart block. And sometimes this could be from tissue inflammation and edema, and the manipulation of tissue causing inflammation, leading to edema around the conduction fibers, leading to heart block. So have to weigh risks and benefits between infections and complete heart block. If the patient comes with a temporary pacer from the valve surgery or the cardiac surgery and he has it and is in the ICU setting, I would typically recommend to keep this. However, I recommend against pacing at higher rate, especially if the patient is doing well, no concerns of chronic or chronotropic incompetence, and just leaving those pacemakers or temporary pacemakers at a lower rate just as a backup. So if in case that the patient, let's say, develops a complete heart block or for any reason, then he will have a backup pacing system. And if the patient is running his own intrinsic rhythm, then the device is gonna sense and it's not gonna pace. Now, this is for, keep this for at least, 4, 5, 6 days if possible, if the patient is going to be kept in the medical, in the ICU or in a setting where the pacemakers or temporary pacemakers can be monitored. Um, if the patient is going to be moved to the ward and on the floor there's some surgical floors or medical floors the nursing don't or they don't have the ability to deal with those temporary pacers, then it comes to the clinical judgment whether if there's a high concern of requiring a pacemaker might lead to the decision of keeping the patient maybe another day in the ICU, but if not, then it can be removed. That way we know that maybe something, nothing happened, patient is his own rhythms, no issues. Now, even with that, post-aortic valve surgeries and some of the valve surgeries, there may be a smaller risk of having complete heart block a week or 2 weeks later, but then, you can't just keep temporary pacing with the patient all the time. So at least for this critical period after the surgery, I recommend having, or leaving or keeping their temporary pacers just as a backup. And that also helps even with if the patient's having complete heart block does help preserving the escape rhythm. The other question, let me just, so your other question was in patients with temporary pacemakers who will need permanent devices, and I think your question was about the timing, whether they should go, the next day or the day after. Um, you don't want to keep those temporary pacemakers for a long time, ideally 48 to 72 hours maximum. And if the pacing, if the patient is, or if the pacing thresholds are getting higher, as we generally see with those temporary pacers, or in some cases where the patient is difficult to control, or if it's annoying to the patient, then I would push for, a permanent device implantation as soon as possible, just to save the team the chaos that can happen around these times. Now, if we have, let's say, two, three patients, I would probably send the one who's requiring higher and higher thresholds every day. Compared to someone who's stable. And then I would if both are stable, I'd probably send the first, or the older temporary pacer, to minimize the time of having a temporary pacemaker and reducing the risk of infection. I hope I answered your questions correctly and didn't miss any part.
Great, Anas. Very well explained. And if you allow me to add some points to what you already say. So I think it's very crucial for all practitioners who doing job in the ICUs to know to start knowing the causes of the causing AV conduction abnormality or complete heart block mainly. And what the patient is going for. So, as Dr. Anas mentioned, we should know the procedure patient going for and what is his risk for coming back from the surgery with needing with the need of a temporary pacemaker. So, if we understand the anatomy of the heart and the AV node that is located around specifically to the aortic valve, so those patients who's going for TAVI procedures, going for valve surgery, mainly the aortic valve, having a higher risk to being dependent at some point. So, what Dr. Anas mentioned initially, those patients we recommend and the guidelines recommend to put a temporary pacemaker for them, either epicardial post surgery or a temporary transvenous temporary pacemakers for TAVI procedures. And for those, we assess their rate and their conduction system immediately after the procedure. So if they having their own rate, then the recommendation to keep these temporary pacemakers and with a low rate, as Dr. Anas mentioned, we don't remove them immediately until we make sure that they will not develop more conduction abnormality in the coming few hours post surgery or days. Now, Dr. Ashwag mentioned also how the ICU staff or physician or fellows trainee can assist or play with the temporary pacemakers. So if you see the temporary pacemakers, the device itself, you can say you can see that it having a setting that you can manipulate, it having the pacing rate. So you can manipulate the rate as you want. If patient having his own rhythm, normal rhythm, then usually we recommend to put backup rate below his rate. Let him do his own and just put a setting, let's say 30 or 40, just in case if he develop any conduction abnormality, then he will pace. So this is the pacing rate. The other bottom or the setting that you can manipulate is the output in the device of the temporary pacemaker. So this is where we measure the threshold of the capture. So we place the temporary pacemaker on the heart, either transvenous or the epicardial one. And the threshold, we should understand, maybe not all of the audience understand what is the threshold meaning. So the threshold is the minimum output that the device can generate or deliver to the heart tissue to capture the heart muscle and causing a contraction for the ventricle. So this is the minimum. So you can play with it every day. Usually, if I have patient in ICU, I go to him and I measure the threshold for a patient, and this should be our daily clinical practice. We go for patient who having temporary, and we start to check their threshold. So we go if their threshold, let's say, we can start from higher up, let's say 10 millivolt, and we go step by step from 10, 9, 8, 7, 6 until let's say at 3, and we keep our eyes to the heart rate, and we see capturing, he's still capturing at 7, he's still capturing at 6, he's still capturing at 5. Then at 4, if I put it at 4, then he lose capturing, then this is his threshold. His threshold will be one step above. So if he lose it at 4, then the threshold, it should be, I would say it's 5. Okay. And the setting that I will place it, usually it should be 2, if not 3, double the threshold. Okay. So if the threshold is 4, I would put the setting on the temporary at 8 or 10 as an output. Okay. So that I will make sure I will deliver enough energy or output from the device to capture the muscle and causing contraction if I need. Okay. And the third bottom, or the setting that you can play in the pacemaker, is the sensitivity. Okay, and that's the sensitivity, meaning how much or how much the device can see from the patient intrinsic contraction, or the wave, or the amplitude. Okay, and we can, if you make it lower than the patient R wave that we see in the ECG, then you allow the device to see patient intrinsic beat. I hope I explain it in easy way to understand, and I hope I get the all question you ask, Ashwag.
Yeah, that was
Thank you, Dr.
great.
Abdullah.
Yeah, sorry to interrupt. Yeah, thanks Abdullah for clarifying this point. One very small comment to add to this is, what we usually recommend trainees, either residents or fellows, in the CCU or ICU setting, is to check these thresholds first thing in the morning, just in case if there were concerns with escalating or rising thresholds, then there will be a time or good time to communicate with the EP team or the device team to arrange device insertion during the day, and saving the team and the patient the chaos that can happen later during the day or in the evening. Thanks.
And another point I would like to raise, when we said before, put the rate the minimum, as long as patient have good heart rate, intrinsic heart rate. But if the patient is in complete heart block, or he is already dependent on a pacemaker, then I would personally, and I'm not sure if Anas will agree with me, to put a pace rate a little bit higher than usual. So I usually in my clinical practice I do it at 80 or 90, just to avoid any extra beat or BVCs coming while patient having slow rate and causing a torsade de poids.
Yeah, exactly. I totally agree with you. I meant when the patient is not pacing dependent and he's having his own intrinsic rhythm, then it's always, ideal to just have it as a backup at 30 or 40. But if the patient is dependent, yes, I agree. Maybe we pace at a higher rate.
Thank you, Anas. I'll take last question from the audience. So Kareem asking if the patient has his normal intrinsic rhythm. I think even slow rate pacing is not recommending unless there is a symptomatic bradycardia or advanced AV block. Anas, would you answer this?
Yeah, so if I get the question correctly, so we're asking if the patient doesn't have an existing pacemaker and he's having a lower pace or a lower heart rhythm, then yeah, if the patient, as the guidelines are very clear, if there's no AV block, and even with bradycardia, if the patient is feeling well and there's no concerns regarding either rest or exertional symptoms, then would recommend against a permanent pacemaker.
Great. I think we reached to the end of this lecture webinar. If no other comment from the moderator, Dr. Ashwag, and my colleagues, I would like again to thank you, Dr. Zahrani, for the incredible and insightful presentation, and taking time to answer the question. Um, I would like also to extend a huge thank to you all of our attendees for joining us today and for your engaging question during the discussion.
Thank you both, Dr. Abdullah and Dr. Anas, for the enlightening presentation. And for the audience, feel free to reach us through our official Zoom channel and join our WhatsApp group to learn together on this journey. And thank you for your time and for joining us today. Thank you so much. Hope to see you soon.
Thank you.
Thank you.
يعطيكم العافية. مع السلامة.